Hi, thank you for the opportunity to present on this topic. I have no disclosures, although I must say I am not a bariatric surgeon or a surgical endoscopist, but I am very thankful for all my experience that I got in my training working on the bariatric and surgical endoscopy rotations in residency, and also for all of my IR, ERCP, and fellow HPB colleagues that I work with in taking care of these patients who have biliary issues after gastric bypass. So first, I was gonna start off, what is a dilated duct? When we look at the images, we kind of see it, but what's the true definition? So from our radiology colleagues, a common bile duct is dilated, or a common hepatic duct is dilated if it's over 7 millimeters. This is usually measured at the proximal duct. The size does increase normally after cholecystectomy up to 1 centimeter. And then the bile duct diameter does increase with age at 1 millimeter per decade over the age of 60. For the intrahepatic ducts, it is a duct that is more than 2 millimeters or more than 40% of the adjacent portal vein diameter. So is bile duct dilatation normal after bypass? In this study from Cleveland Clinic, it's a retrospective study that looked at 33 patients who had pre- and post-bypass imaging at least 3 months after their gastric bypass. And from this, it shows that the bile duct diameter does increase, particularly if there is an intact gallbladder. In their follow-up study, they looked at both the bile duct diameters with patients with Roux-en-Y gastric bypass and those with sleeve gastrectomy. And on average, there was an increase of 1.4 millimeters after Roux-en-Y gastric bypass, and for sleeve gastrectomies, an average increase of 0.5 millimeters. This is particularly for the Roux-en-Y gastric bypass in this series, this is regardless whether they had a cholecystectomy or not. In terms of the differential diagnosis of patients who have bile duct dilatation and stricture, there are benign etiologies, such as those are related to gallstones, such as choledocholithiasis and Ritzi syndrome, sphincter of Oddi dysfunction, which we just talked about. And there's also a term that the Cleveland Clinic group called ampullary achalasia for those who had a dilated common bile duct more than 15 millimeters. There could be stricturing and dilation from pancreatitis, ischemic or iatrogenic strictures. There could be calculus in the intrahepatic ducts, and for those that have bile duct dilatation and strictures in both the intra and extrahepatic ducts, primary and secondary sclerosing cholangitis. The one etiology that we do worry about, though, is making sure that we don't miss a malignancy. There's various malignancies such as cholangiocarcinoma, pancreatic cancer, ampullary cancer, and then also metastatic portal lymphadenopathy causing stricturing and narrowing. In terms of the workup, first it's initially non-invasive imaging. Usually the bile duct dilatation is detected on ultrasound or CT scan, and then followed up by MRCP. Of note, if the patient has had recent surgery, pneumobilia on MRCPs can limit evaluation of choledocholithiasis. In terms of interventional radiology, if the patient presents with cholangitis, usually I send them straight to IR so that they can get immediate transhepatic biliary drainage. The pros of going to IR is that there's immediate biliary decompression, a cholangiogram to define the anatomy. They can do interventions such as balloon sphincteroplasty, lithotripsy, and brushings. This buys time for other interventions in a septic patient and is more useful for those who have intrahepatic duct dilatation. The cons, though, that it usually requires external drain after the procedure, and the tissue diagnosis is limited to brushings, which may not be as sensitive. In terms of endoscopic procedures, essentially this is ERCP, but there needs to now be a new way to get to the papilla. So Dr. Baker already went over transgastric ERCP. This can be either done laparoscopically or percutaneously. Double balloon enteroscopy, so having a long enough scope that can get to the papilla. Although this increased length, even once you get to the papilla, there can be issues with the angulation of the scope, looping, and going through adhesions. and then also endoscopic ultrasound-directed transgastric ERCP, or what's otherwise known as EDGE, where there's ultrasound-directed lumen-opposing metal stent placed between the pouch or jejunum to the remnant stomach, and the duodenoscope is then passed through the stent. In terms of transgastric approach versus double balloon enteroscopy, in our Indiana experience, double balloon enteroscopy has fallen out of favor. This is due to the lower cannulation rate, about 60% with double balloon enteroscopy, the lack of having a side viewing scope, a smaller working channel, which means less instruments that can be used for interventions. The max diameter of the stent that can be placed is 6 French. And they also believe that an aggressive sphincterotomy can't be performed. It's difficult to place and remove pancreatic duct stents. And then sphincter of Oddi manometry is not feasible using this approach because the catheter is shorter than the scope. They also found that there was a longer procedure time, 101 minutes on average, compared to doing a laparoscopic transgastric ERCP. So our endoscopy group has now favored doing the EDGE procedure, which is, as I mentioned before, this usually requires at least 2 procedures and sometimes 3 procedures. So the first is an ultrasound-directed placement of a lamin stent between the pouch or jejunum to the remnant stomach. The next step can either be done at a subsequent procedure or sometimes is done on the same procedure, where the duodenoscope is then passed through the stent. Then the interventions are done, such as removing, in this case, a common bile duct stone. And then the third procedure is to remove the stent and doing an endoscopic suturing of the gastric fistula. In this international multi-center comparative trial of double balloon enteroscopy versus the EDGE procedure. The EDGE procedure was favored, although multiple procedures are required. So that, in a way, is good if you're looking at someone who has, say, for example, sphincter of Oddi dysfunction or will need multiple stent exchanges. The technical success is reported to be up to 100%, but one of the feared complications is persistent GG fistula and weight gain, and also theoretically there could be perforation of the stomach. In our group, we actually do a lot of laparoscopic, transcystic, and common bile duct exploration for patients who have Roux-en-Y gastric bypass anatomy. So if the gallbladder is in place, then the transcystic intraoperative cholangiogram and bile duct exploration is preferred. You can do this as was done traditionally with a choledocoscope or ureteroscope. I found the smaller ureteroscopes are harder to use because they're not stiff enough sometimes to cannulate, but then the larger ones require larger cystic duct. And through that, we can do stone extractions, balloon sphincteroplasties. There's laparoscopic common bile duct exploration kits that can be used, such as the one by Cook. As of last year, we started using the Spyglass Discover. This is similar to what the ERCP group uses, except it's shorter and done better for laparoscopy procedures. This is from Boston Scientific. It has great visualization. It's much easier to maneuver compared to the ureteroscopes. In terms of instruments, there's a basket. I think in development is a snare forceps, but that's not commonly with a kit. The downfall is if you needed to do a balloon sphincteroplasty, you can't, whereas you can do that with the laparoscopic common bile duct exploration kits. So this is my algorithm of how I manage common bile duct dilatation and strictures. So this probably will be dependent on what resources that you have in your hospital. I'm fortunate at IU that we co-manage most of our patients who have these issues. There's a very large ERCP group as well as HPB group, and we're all situated next to each other. Our OR is next to the ERCP suite, which is next to the IR suite, and we have a weekly multidisciplinary conference for non-malignant HPB issues. And what's unique to our system is that we also have a dedicated number of what we call ERCP beds that are reserved for patients who have issues that need ERCP. So it's very easy for patients in Indiana to get transferred in. And bed access isn't an issue, even in these COVID times. So as I mentioned before, if the patient is septic or has cholangitis, I usually refer them to IR first because it's the quickest and most reliable way to decompress the biliary tree. As a surgical oncologist, I must say on there, if a mass is seen, then follow the typical oncologic algorithms. Do the staging scans. Sometimes there's mets that can be biopsied that will be easier to get tissue. Tissue is a priority, but if getting a tissue diagnosis is not feasible, then would just presume that it's malignancy and resect if it's suspicious. If there's no mass, the gallbladder is present, there's a normal bilirubin, and repeat interventions are unlikely, then we usually default to doing lap choles with common bile duct exploration or lap-assisted ERCPs. If the patient has already had a cholecystectomy, so then the cystic duct is not a good point of access. If stenting is needed or repeat interventions are likely, then we usually go for either the edge procedure or a transgastric ERCP. So the considerations in terms of this algorithm is OR availability. We did default more to doing the edge procedures when there was lack of OR access or difficulty getting OR access during the COVID pandemic. Other considerations are the number of anticipated interventions that are needed, staffing issues, so whether you have surgical endoscopists in your hospital where it's easy to do lap-assisted ERCPs without having to coordinate between the surgery and the ERCP group. And then what the patient desires in terms of the potential of having a gastric fistula and potential for weight gain. So in summary, a management of biliary disease in patients with room-wide gastric bypass can be challenging, but can be overcome. There's multiple options that exist, combining IR, endoscopy, and surgical management. And the management algorithms are tailored depending on what resources you have and the experience of your team. And for us, I found multidisciplinary management to be very helpful.